Welcome to The Explainer. Today, we're diving headfirst into the world of medicine to crack open a fascinating and pretty rare case file. It's a true medical mystery that presents this unique, high-stakes challenge for even the most skilled surgeons out there. So let's get right into this puzzle. It all kicks off with a really dramatic, really alarming symptom that almost always pops up in one very, very specific type of patient. And it leads doctors down this tricky path where one of their most basic tools is completely, and I mean strictly, off limits. All right, so our investigation starts with the classic signs, the red flags that tell doctors, hey, this is not just some ordinary thing we're dealing with. And right away, the profile of the patient is pretty much everything. The case almost always shows up with this unmistakable trio of symptoms, and it's always in a teenage boy. First, you get a blocked nose, but just on one side. That's the start. But the real giveaway, these recurrent, severe nosebleeds. We're not talking a little drip, we're talking profuse bleeding. That's the real alarm bell. And when a doctor takes a look, they usually find a mass way in the back of the nose. And there's a reason this is so specific. This condition is incredibly rare. I mean, to put this in perspective, these things, called juvenile angiofibromas, or JAs, make up just 0.05% of all tumors in the head and neck. That's it. It's so rare that a lot of doctors might go their entire career and never, ever see a single case. So what in the world is this thing? Why does it act so aggressively, and what makes it bleed so dangerously? Well, the answer is all in its very unique, very weird structure. You know, on paper, it's defined as a benign, non-cancerous tumor. But honestly, that label is dangerously misleading. Sure, it won't spread to your lungs or liver like a typical cancer, but right where it grows, it is incredibly aggressive, just invading and destroying everything in its path. And this right here perfectly captures the whole paradox of JOA. On one hand, you see its dark side. It's locally aggressive, it invades structures, pushing into sinuses, the eye socket, even creeping up towards the brain, acting just like a cancer would. But on the other hand, it has this kind of halo. It's technically benign because it doesn't metastasize. This dual personality is exactly what makes it such a huge clinical challenge. So why does it bleed so much? Well, it's because it's less of a solid tumor and more of a tangled mess of blood vessels, a vascular malformation. And these vessels are abnormal. They don't have the normal muscular wall that lets them squeeze shut. So once they're cut, they just can't stop bleeding. They're like faucets with no handle. Now, here is a super important detail. This whole mess starts in a very specific, very tiny spot. The tumor almost always grows from the area right around something called the sphenopalatine foramen. It's this little gateway at the back of the nasal cavity. Think of that as ground zero. And from that exact starting point, the tumor follows a surprisingly predictable path. It's not random. It spreads like a vine, creeping through the body's natural cracks and openings. And the path it takes, that directly determines what symptoms the patient is going to have. Check this out. It's a perfect illustration of that connection. If the tumor grows sideways, laterally into a space called the infratemporal fossa, boom, you get swelling in the face. If it grows upwards, superiorly into the eye socket, you get a bulging eye, which is called proptosis. The tumor's route directly maps to the clinical signs. It's like a roadmap of destruction. As it spreads out to the side, it literally pushes on the bone right behind your cheek, in the maxillary sinus. And on a CT scan, this creates a classic telltale sign that radiologists look for called the Holman-Miller sign. Seeing that bone bowing forward is like the smoking gun on the scan. It practically screams juvenile angiofibroma. Finding these clues on the scans is absolutely essential because it lets doctors put together a very high-stakes surgical plan without ever having to do a standard procedure that, in this case, is completely forbidden. And that brings us to the single most important rule in managing this tumor. The one thing doctors almost always do to identify growth, take a little sample, a biopsy, is completely off the table. It is absolutely 100% forbidden. Trying to biopsy a JA without the proper setup is a recipe for disaster. So why? What's the big deal? Well, it goes right back to the tumor's anatomy. Remember those weird abnormal blood vessels that can't squeeze shut? A biopsy is basically a little cut. If you do that, you trigger immediate, massive, and potentially life-threatening bleeding that you just can't easily stop. So instead of a biopsy, the diagnosis is made by piecing together a puzzle. You have the clinical picture, teenage boy, bad nosebleeds. You combine that with some high-tech imaging. The CT scan shows those classic bony changes, like the Holman-Miller sign. An MRI shows exactly how far the tumor has spread. And then, an angiogram gives you a perfect roadmap of its blood supply. So, with the diagnosis confirmed, the treatment is this really elegant two-step strategy. Step 1, about a day or two before the actual surgery, an interventional radiologist goes in and performs an embolization. They basically block the main arteries feeding the tumor. In simple terms, they cut the fuel lines. It's only after that blood supply has been choked off that surgeons can finally move in safely. They use modern endoscopic tools, going in right through the nostrils, and now they can take out the mass without that terrifying risk of a massive bleed. But even during that surgery, there's one single move that is more important than anything else. It's the one step that decides whether this tumor is gone for good, or if it's going to come roaring back. To make sure this thing never comes back, surgeons have to go right to its origin point and deal with it. This means using a special drill to meticulously remove the bone at the pterygoid base, which is right where the tumor is most firmly attached. For experts in this surgery, this step is completely non-negotiable. And just look at the difference in outcomes here. It is night and day. If the surgeon drills that base, the tumor's root is gone. Recurrence is very unlikely. But if that step gets skipped, microscopic bits of tumor get left behind, and there's a really high chance it'll grow back. In fact, failing to do this is the #1 reason these tumors recur. So when it comes down to it, this final decisive action is what separates a cure from a comeback. You can take out 99% of that tumor, but if you don't dig out its origin, you haven't really solved the problem. You've got to get the root. And that leaves us with one last really fascinating clinical question. What happens if a tiny piece is left behind, maybe stuck to something critical like the optic nerve? Do you go back in for another risky surgery to get that last little bit? Or do you just watch and wait, knowing that sometimes these little leftover pieces don't even grow back? It's a really tough call, and it's just one of the many dilemmas surgeons face when they're trying to solve this